attend this. Thank you all for coming to attend this meeting, especially this cold Wednesday afternoon in Missouri. I'm going to talk about suicide in jails and prisons, basically concentrating on the following items. I'll introduce myself in a bit detail, then we talk about the objectives of the talk, scope of the problem, and I share with you 3 anecdotes from my personal case histories. Then we talk about suicide losses. Then we'll cover suicide prevention, reasons, challenges. Then method of suicide and mechanism of death, and suicide prevention and treatment. So I'll try to do the whole agenda or topics in about 50 minutes, leaving some time for us to share ideas, thoughts, for you to ask questions and me to provide some answers. Who am I? I am Dr. Daniel, a forensic psychiatrist. I'm an adjunct professor of psychiatry at the University of Missouri School of Medicine, and also an expert consultant in forensic psychiatry. I am the author of Suicide in Jails and Prisons, Preventive and Legal Perspectives, a guide for correctional and mental health staff, experts, and attorneys. Now, this book reflects my experience, research, clinical practice, consultations on suicide in jails and prisons. I was fortunate to be the Director of Psychiatric Services for the Missouri Department of Corrections for about 7-8 years in early 2000. And just before that, I was a consultant to Boone County Jail. Based upon my experience, I have gathered quite a bit of information on suicide in jails. In fact, the director of the Department of Corrections in early 2000 gave me the opportunity to review suicides in DOC, Missouri Department of Corrections, between 1992 and 2000. We had about 37 cases. I analyzed those cases in terms of risk factors, what motivates people to take their lives, and the psychiatric diagnosis, the method they have used, and the preventative measures that we are supposed to take. So I gathered all those information and published a paper which was well received in the Journal of Correctional Healthcare. And from there on, I was intrigued and touched by various factors, which I ventured into looking in more detail about suicide in jails and prisons. Subsequently, I participated in postmortem review, or psychological autopsy, they used to call it, in DOC. We had about 18 cases. And subsequently, after I left the Department of Corrections, I was consulting on a number of suicide-related lawsuits across the country, from Hawaii to New York. And in fact, I have consulted, as of now, about 90 cases. So I have wealth of experience to share with you this afternoon, basically analyzing about 130 suicide cases. So the objectives of the talk today are basically 4: how to prevent suicide, how to save lives, avoid lawsuits, and save millions of dollars. If you look at these 4 objectives, actually you can break it into 2 major sub-areas: preventing suicide and thereby, of course, saving lives, avoiding lawsuits, and saving millions of dollars for the jails and the DOCs. The average settlement in a suicide-related case is about $300,000. The upper end would be $3, $4, $5 million even. In fact, I was involved in a case in California where the settlement was about $5 million. I'll talk more about that kind of situation a little later. Okay, what is suicide? Suicide is an intentional act of self-destruction. It begins with an idea, and most people end up having only the ideas. There's nothing further beyond that. However, in certain individuals, the idea proceeds to basically a plan with consideration or access to means, making a suicide attempt, and of course, completing suicide. So this is a continuum from ideation to completed suicide. At any point in that continuum, intervention can happen and suicide can be averted. Moving on, suicide is a major public health issue in the United States and worldwide. It is the #1 cause of death in jails. In fact, right up with the cardiovascular disease causing death in inmates in prisons or in jails, whereas it is the 3rd cause of death in prisons, right up with #1 being cardiovascular disease, #2 being malignancies or cancer. What is the extent of the problem? Worldwide, 1 suicide attempt every 3 seconds. 1 completed suicide every minute. Typically, more people die by suicide than from major international conflicts. We have some statistics for 2020 in the US. 45,173 people took their lives in the US. That I'm talking about, including the incarcerated population. I'm talking about the general public in 2020, and it is rising. The latest figures I have come across is that in 2021, it was about 46,000, upper end of 46,000. There was at least a 5 to 7% increase. Whether this is attributable to COVID, we do not know yet. We are waiting for the statistics from the Bureau of Justice. Who are the most vulnerable people? They could be young males or elderly males. They may belong to indigenous group. But more importantly, they are people with mental illness, people with alcohol or substance abuse, people who have previously committed suicide. If you take a look at this list, basically, a young person can have mental illness, who may be addicted to alcohol and drugs, and who may have attempted suicide. Taking all these factors into consideration and applying to the jails and prisons, we have come to learn that persons in custody, that is behind bars, are one of the highest risk groups. So a person in custody can have mental illness, any number of mental disorders, substance abuse, and who previously attempted suicide. The last factor is highly significant. Somebody who has previously attempted suicide, stands at a high risk for completed suicide. Let's talk about the suicide occurrence per 100,000. When we talk about suicide in the general public, as well as in any cohorts, we talk about number of people who took their lives per 100,000. In the general public, it's about 12 people annually take their lives out of 100,000 people. In jails, historically, when I talk about historically, we are talking about a period before 2000. The occurrence was somewhere between 52 and 129 per 100,000 people. And currently it is at 46, which is 4 times higher than the general population. In the state prisons, it's about 24 to 40. Before 2000, currently it is 17. And in federal prisons, it was 10 to 17. Currently it is at 10. By the way, in the United States, we have about 3,134 jails, 1,112 prisons, 112 federal prisons, number of military operations, military jails, number of jails in the Indian population as well, number of ICE, Immigration and Customs facilities. So on an average annually, as you all know, we have 2.2 million people behind bars. This number has been consistent for the last number of years. So in the world, 4.4% of the world population live in the United States. However, we have 22% of the entire incarcerated population. So look at the statistics. There is a recent uptrend since 2015 in jails and state prisons. And the common method used by inmates to kill themselves is hanging. That is 90% of them. However, 33% of the people who kill themselves do so without any warning. What is the impact of imprisonment? As we know, people are removed from their homes, from their community, and placed in jails and prisons. They are isolated. Particularly, they suffer from sensory deprivation in restricted housing, such as maximum security prisons. And those who are removed are arrested and placed in custody. They lose their prestige, loss of freedom, and they may suffer from some guilt and shame for the arrest itself, or maybe sometimes for the crimes they have committed. And the jail population have especially after suicide, there is a higher potential for litigation lawsuit. Let me share with you 3 case histories quickly, and you might be able to read on the slide there. We have a 25-year-old young white man who was convicted of a minor offense and was sentenced to 3 years in a minimum security prison. Because of his rule-breaking behaviors, he got more and more restrictions, ended up in a maximum security prison. His family refused him if paroled. This broke the proverbial camel's back. Frustrated with the prospect of serving the maximum duration instead of the customary 85%, he took an impulsive action to hang himself. Next, let's take the case of a middle-aged white woman, first time ever in jail, convicted for what she believed was unjust because her husband she killed was unbelievably abusive and violent to her. He was in fact atrocious. Yet she was overtaken with guilt that she could not bear. She used a bedsheet in her cell to hang herself. So here, an important point that I would like you to keep in mind. Women less often take their lives in prison or jail. More women attempt suicide than men, and more men die by suicide in jails and prisons. Take the case of the third case, a middle-aged man, well respected in the community, but had a secret private life, one of sexual exploitation of his stepchildren. he became severely depressed and took his own life by hanging. So all these people kill themselves by hanging. So that is the predominant method by which people kill themselves. So let's talk about the losses. Who suffers the most? Of course, the person who killed himself or herself, particularly their family. But let's consider the staff. Those of you who work in jails and prisons, this is an important point. Many of the staff who intimately work with detainees and prisoners or offenders, they feel shame and guilt for having missed the opportunity to save a life. They may feel that something they have not done may have caused the death of this person. But in addition to that, the staff has to spend an enormous amount of time to deal with the after effects of suicide. Namely, they have to participate in internal and external investigation. They may be dealing with the police. They may be dealing with debriefing, and they may participate in mortality, morbidity reviews. And also they will have to take time through a process of what is known as audit. Some of you may know that, to reassess the policies and procedures and to modify the policies and procedures depending upon what they have found in psychologically autopsying the case after a suicide. Secondly, what happens to the family? The next of kin experience some sort of dual pain, the pain of losing a loved one, and the pain of not able to find out what happened to their next of kin in a jail or prison. Because our system is a closed system. The system, if you take any jail or prison, they won't give out any information. They may be instructed to do so, but by and large, little information comes forth. So the only choice for the survivors is to hire a lawyer and file a lawsuit. This way, through the discovery process, they may be able to find out what happened to their next of kin. Now, why do we prevent suicide? Of course, saving a life is extremely important, and of course to avoid a monetary loss. But look carefully beneath these two fundamental aspects of prevention. And I have come up with 4 reasons why we have to prevent suicide. 1, saving a life adds to the professional and personal satisfaction and worth to those who work in jails. And it's a common view that people work for a paycheck, but those of us who are professionals and even non-professionals, and they go to work to get personal and professional satisfaction. And that's an important component. I put that as the top of the list as one of the reasons why we engage in the business of saving lives. The next is meeting the professional standard of care. Of course, the standard of care is established by each professional discipline: psychiatry, psychology, social work, etc. So one of the reasons why we have to meet the standard of care is, of course, is to institute adequate health care, medical and mental health care. But it's also meeting the standard of care is is also statutorily guided based upon statutory guidelines that we have to engage in the act of professional meeting the standard of care. Third, we should meet the four classic elements of care. One, we have a duty of care to the inmates. And if you breach the duty of care, it will cause damage in terms of injuries, in attempted suicide, or in case of death, in suicide, death occurs. But in order to prevail in a case of medical negligence or malpractice, we have to establish a direct or proximate relationship between the damage and the breach of duty. That's how the plaintiff wins a case. So the medical malpractice or negligence claims are directed against clinicians, psychiatrists, psychologists, social workers, physicians, etc. And medical negligence cases are rarely successful, although duty to care is inherent in the relationship. The legal proof required to prevail in a medical malpractice or negligence case is preponderance of the evidence, which essentially translated into simple terms is more likely than not that there was a proximate relationship between the damage and the breach of duty. In terms of percentage, which I don't like to use, but it is 51 to 49%. Next reason why we prevent suicide is to protect the constitutional rights of the detainees. If you look back at the history of mental health and medical care in the correctional system, back in late 70s, the Supreme Court of the United States has established that there is a constitutional right for the detainees to receive adequate medical care. Subsequently, mental health care has been incorporated into medical care. So there is no distinction between medical care and mental health care as far as the constitutional rights are concerned. And then later, in considering what is the appropriate care, case law has come up with the concept of what is known as serious medical need. A serious medical need is something which has been professionally diagnosed. What does that have to do with legal action? If the correctional officers or the mental health professionals working in the system, particularly the healthcare professionals, identifies a serious medical need and then intentionally or purposely disregard, that means not taking any specific action to mitigate that risk, that will form the basis of a lawsuit based upon deliberate indifference. So when we are dealing with jails and prisons, not only the cases are centered on medical malpractice or medical negligence or correctional negligence, but there's a whole host of cases related to deliberate indifference. The basis being that the caregivers have deprived the person's constitutional right of adequate mental health or correctional or mental health or medical care. So in the historical evolution of the concept of deliberate indifference and serious medical need, one of the landmark cases was Farmer versus Brennan, which was decided in 1994 by the Supreme Court of the United States. I believe Mr. Farmer was a transgender. At that time, it was described as transsexual inmate in Terre Haute, Indiana, I believe jail or prison, I don't particularly remember, in which he was assaulted and raped, and he claimed that his constitutional right of personal security was violated when he was assaulted by the other inmate, and the system did not protect him. In this particular case, excuse me, writing for the majority, Justice David Souter identified that the person has a constitutional right to be protected. And he basically opined that the staff did know that he had a particular serious security risk, and the risk was ignored at that time. So then, based upon those cases, in terms of psychiatry, what we have come up with a list of conditions which are probably diagnosed by psychiatrists, psychologists, social workers. They include mood disorder, psychotic conditions, acute crisis, suicide risk, all of these things. An assessment of probability of serious risk of harm is considered a serious medical need. If you fail to identify an inmate's potential serious suicide risk, that is one important component of it. But if you identify such risk and then fail to take action to mitigate the risk, for instance, if you fail to screen, that could be a basis for non-identification of risk. And if you screened and identified the person has a potential for suicide, but did not place him under suicide observation, then you are disregarding or ignoring that potential risk. So failure to assess suicide risk and if found, failure to intervene form the basis of deliberate indifference. Okay, how do we prevent suicide? I will discuss basically into two broad situations. One is people who work in jails, the staff, both the correctional staff and mental health staff and medical staff, has to be perceptive of emotional and mental health needs. This is partially an art form, intuitive, using clinical judgment to be to raise your awareness of potential risk of an inmate. And then secondly, follow policies, procedures, and practice. There's a dictum in lawsuits, in legal situations that I have come up with. Failure to follow policies, procedures, and practice can be fatal to the inmate, and figuratively fatal to your reputation and purse. So that is important. Those of you who are working in jails and prisons must carefully follow policies, procedures, and practice. Of course, there may be situations where no well-designed policies, but nowadays, after having, after the constitutional right was established back in late 1970s, most prisons and jails in the United States have well-designed policies, procedures. Implementation might be a problem, but broadly stated, these are the two aspects we might have to take into consideration to prevent suicide. Then, in terms of real nuts and bolts, doing screening, we have to identify risk factors. The risk factors can be divided into static risk factors, and dynamic risk factors. Static risk factors are non-variable factors, that is, the age, sex, race, the type of crime the person has committed, or the charges they came with, the fact that it could be mentally ill, substance abuse, and institutional factors of being assigned to a maximum security unit or isolation or administrative segregation. Those are all non-variable factors. But there are some dynamic factors. The dynamic factors could be loss of a loved one, custody situation, divorce situation, a new crime, a new charge, an additional sentence while they are incarcerated. All of these are dynamic factors. So what I'm driving at, not all people who have all the risk factors and not all people who have dynamic factors end up killing themselves. There should be an interplay between the dynamic factors and the static risk factors. So at a certain point in the inmate's life, acute vulnerability occurs. People who have some of the static risk factors, when faced with, say, for example, an additional sentence of 10 years, or a denial of parole, or an unexpected sentence happens, that is the most vulnerable period for the detainee or the offender. Staff must be perceptive of this particular critical period in time and spend time with the inmate, talking to them and exploring the reasons for despair, despondency, and depression. So that is important. The reason being, all suicide thoughts are transient. This fundamental principle is true for anyone in the community, not only in prisons or jails, but all suicide thoughts are transient. So intervention can occur and should occur during this period if possible. Now, in working with jails and prisons during the last consulting during the last 25 years, I have come up with 14 scenarios or challenges that I should say is problematic in terms of prevention and in terms of avoiding lawsuits. I put communication issues at the top of the list. The communication is fundamental in a multidisciplinary treatment team setting in jails and prisons. The communication failures can occur between the mental health staff and the correctional officers, between the nursing staff and the psychiatrist, between the scheduler of appointments with the psychiatrist, between the family and the jail staff, between the inmates and the officers, etc. All levels of communication problem. And nowadays, people, we have the system, electronic system, all entries are made in the EMR. And of course, you may enter all of those important information in the EMR, but a mental health professional may not review all the preceding information unless there is an alert placed on the screen. And I have come across in several cases, the alert system was lacking, even though the system was in place, it was not activated. Therefore, there was miscommunication between the screener and the mental health professional, who failed to identify the high suicide risk of an inmate, and that particular mental health professional, in few cases, they end up paying dearly at the end of the case. So you have to be alert on the lookout for the suicide alert in the system. Another problem is a failure of the intercom system. In jails, Each cell is equipped with an intercom system where it can call for help. But sometimes it so happens that the control room may intentionally or unintentionally mute the system, so the inmate may not be able to communicate with the control room. I have had 2 cases which I have described in my book, where failure of the intercom system and active, quote, silencing of the intercom was identified as a major factor in that litigation. Next is screening. Screening is important. Almost all jails and prisons in the United States have a screening system. They screen the individual when they come in for suicide risk. But sometimes screening is done in a mass. A lot of detainees, a lot of arrestees are grouped in a hall, and then the officer will ask a question like, "Are you suicidal today?" Everybody says no, but there is no individual screening. So that is a problem there. Next is delay in psychiatric care. Many individuals who come into the system come with psychiatric disorders on medication. If they delay providing services, that could be a problem. Scheduling appointments and follow-up is a problem. The policy might state and procedure might state that you have to see a chronic patient every 30 days, but sometimes it so happens that it ends up 3 months. That could be a problem. Renewing prescriptions as they come into the system would be a problem. Not bridging medications when inmates enter the jail, that could be a problem. Then lack of treatment for substance withdrawal. This is an important point. A substantial number of detainees come into the jails intoxicated with alcohol or drugs, and they are at potential risk for suicide within the first 72 hours. And first 72 hours for alcohol, and up to 72 hours, 7 days for opiates. So up to 7 days is the most vulnerable period. Most suicides in jails in the United States occur within the first 48 hours. That is important. The sheriffs, the wardens, the captains, etc., should be fully aware of this potential risk. Lack of training is another important point. Training, of course, is fundamental for keeping up with the developments in our field. So there is a mandatory requirement of 4 hours of training in when an officer is appointed or is hired into the system, and then they have to have a refresher training every 2 hours of refresher training every year. But for professional psychiatrists, psychologists, and social workers, we are required to continue with our license. We are required to take continuing education. So these are the 5 areas that I have identified. So what is the method of suicide? As I have mentioned, hanging is a predominant method, 90% of the cases. And of course, firearm is not available behind bars by and large, but in the community, firearm is the most used method of suicide. In terms of hanging, only 2 kilograms of pressure is required for the hanging body. It can be accomplished by kneeling, sitting, and using any anchor points which is available in the cell. It takes about 5 to 7 minutes to actually make a noose, put it around the neck, anchor it to an anchor point, and hang yourself. And the important point to remember is that the suicide can occur, the death can occur within 5 to 7 minutes, and significant damage can occur. Brain death can occur in 3 to 5 minutes. And if you are a young, robust young man, the death can be delayed a little more. Hanging is one of the methods where 70% success rate. Drug overdose is the second most common, mostly using drugs with lethal potential, such as tricyclic antidepressants, which is not commonly prescribed anymore. But in maybe early 2000, it was very common. But nowadays, people use SSRI, SNRI, and other non-medications with non-lethal potential. There is, in some jails, there is what is known as keep-on person medications. Certain medications are allowed to be kept in the body of the person, especially life-saving medications such as nitroglycerin, inhalers, and things of that nature. I was involved in a particular case in a different state, where a keep-on medication, namely verapamil, which is an antihypertensive medication, was used to kill herself. She used about 3,000 milligrams of verapamil and ended up dying. Other uncommon methods of suicide: hunger strike, homicidal hanging, self-immolation, self-cutting, drinking cleaning fluids out of a cleaning cart from the housekeeper. Mechanism of death by hanging. There are 4 basic mechanisms. You can read the details in my book. They are respiratory asphyxia, occlusion of cervical blood vessels causing cerebral anoxia, cardiac inhibition, and snapping of C2 or C3 vertebra, which is quite common, which is the basic mechanism in judicial hanging, wherever it is practiced. Suicide prevention, how to prevent suicide is basically, it is a collaborative responsibility. It is the joint working together with correctional staff, medical staff, mental health staff, and administration. There are 7 key steps, which includes identification, screening, assessment or mental health evaluation, which suicide risk assessment, etc.
Okay, it looks like we lost Dr. Daniels there. Hopefully he'll be coming back to us here in just a moment. We're almost at the end already, but you'll hold on, please. Hopefully he'll be reconnect with us here in just a moment. While he's reconnecting, let me go ahead and tell you about some other upcoming programs we have. On tomorrow, actually, trauma-informed care, ethical considerations will be happening at 1 o'clock on the 28th. Breaking intergenerational patterns of trauma, addiction, and dark secrets in families will be happening. And then, oh, here he comes back. And then on December 1st, how to become a better grant writer. So we'll let Dr. Daniel get reconnected here. And we'll get started again.
Okay.
Yeah, we just lost you. If you want to go ahead and turn your camera on, Dr. Daniel, I know you're getting close there.
Okay, all right. All right.
Now, we don't have your slides back up yet, but
okay, let me get that. Somehow the power went off.
Yeah, well, the winds are kind of strong, so I don't know if that had something to do with it, or,
Okay.
but we'll just pick back up here as soon as you're ready.
Yeah, I am getting there.
I figured something like that happened. I'm glad you're back with us.
Okay, all right.
Oh, we don't see your slides yet, though. If you go ahead and escape, and then go down and hit share screen, and then once you share your screen, just pick your PowerPoint there.
Escape.
You might have to minimize your slides just for a minute while you share your screen.
Okay, all right. Can you see me now?
I see you, but I don't see your screen yet.
Can you see?
Not yet. No. Sorry.
Okay.
But I mean, you're close to the end. If you can see your slides on the screen, I'll send them out to everybody if you just want to go ahead and
yeah.
continue.
Okay. Yeah, I'm almost at the end. Okay. So, can you see me now?
Yeah, we can see you. So go ahead.
Yeah,
And
then
continue.
I can go ahead and talk. Basically, I don't need the slides, but we can send it out when I send it to you. So basically, suicide screening there's 12 significant risk factors which are commonly used to develop a suicide screening checklist. That could be current, including these items such as the inmate. Does he have current thoughts of suicide? He has a history of treatment for mental health problems, current symptoms of psychotic disorders, history of previous suicide attempt, level of intoxication with drugs or alcohol, the history of anxiety, depression, or any other identifiable disorders. And then one of the significant aspects of screening list, which many jails have used, is the arresting officer's belief that the inmate, he or she is suicidal. That is a subjective assessment by the arresting officer. Generally, that is taken into consideration in evaluating potential suicide risk. Why do we screen? The main reason for screening is to identify the potential risk, but more importantly is to assign suicide observation measures. It can be placement in a suicide observation cell, then monitoring the inmate every 15 minutes, or constant watch, or downgrading it to 30-minute watch. Then suicide screening leads to mental health or psychiatric evaluation to establish a diagnosis and to institute appropriate treatment. That is the purpose of screening. And from a legal standpoint, if a system doesn't have this screening mechanism, that could be an important liability. Lastly, I'm moving on to treatment consideration. The treatment considerations are multifold. Mainly, it involves beyond the evaluations and suicide risk assessment is monitoring potentially at-risk individual, then begin treatment in terms of cognitive behavioral therapy, which are seldom done in a jail or prison, but medications are the mainstay for identified mental health disorders. Those who are gravely disabled, we can institute what is known as involuntary medication. process, but generally chronic care is provided in psychiatric outpatient clinic, treatment of psychotic disorders, depression, anxiety, etc., etc. Then finally, some measures are to be provided in terms of designing the jail cell, which of course I have identified in the slides. You can read about that. But to conclude, screening, monitoring, and treatment are mainstay in prevention of suicide. With appropriate identification of individuals at risk and being perceptive of their emotional and psychiatric needs, and following policies and procedures, we can save large number of people, at least 60 to 70% of people, and we can avoid lawsuits and save millions of dollars. I'll stop here, leaving about 7-8 minutes for question and answers and discussion. I'm sorry about the electric outage. I'm sorry about that.
Oh, no problem. We can't hold you accountable for the electric power in the whole area there, so no problem. So if you want to, folks, you can type your question in the Q&A. You can put it in the chat if you want to, and I'll ask your question for you. As we transition here to Q&A, please type it in whenever you're ready, and I'll ask it. But I also just mentioned that what's going to happen then after we get done is you'll get an evaluation link in your inbox. Please fill that out if you don't mind. And that way we get some feedback on everything. And I'll pass that on to anonymously to Dr. Daniel, and he'll have that as well for as he shapes his talks into the future. So any questions, you can type it in chat or Q&A. I've got a question here in the Q&A. Dr. Daniel says, can the court order mandatory medication compliance? If so, what is that process?
Yeah, I have, in fact, that's a good question. In fact, I had a case out of Wisconsin where the court has mandated treatment. But the court cannot specify what treatment to be provided, what medications to be chosen, what dosage and specifics, etc. But compliance, if that is a problem, we can go back to court and petition or inform the court to subsequent action. But if a person, even though the court mandates treatment, the detainee or the offender may refuse to accept treatment, in which case then involuntary treatment has to be instituted. But that is a laborious process and that takes time. So that's the situation there. I had a case out of Pennsylvania where the judge has issued order to the warden to provide treatment for substance abuse. And of course, in that particular case, the warden has not paid much attention to it. And that case ended up being settled for a large amount.
Thank you, Dr. Daniel. Next question is, do you have any advice pertaining to jails who refuse to give medications prescribed by a physician to a person in their care?
Well, my advice is, it depends upon what level is that. If it is nursing staff, of course, they are professionally obligated to dispense the medication. If it is a correctional officer who is trained to dispense the medication, then of course the responsibility has to shift to the nursing staff. But the usual administrative process has to take place if somebody is it out of any religious convictions that they are not distributing? I don't know. But by and large, psychiatric medications are dispensed by the nursing staff, except in rare occasions dispensed by trained correctional staff, especially after hours.
Okay, thank you very much. Our next question is, do you have any suggestions for how attorneys and social workers who work with the attorneys specifically can play a role in suicide screening and prevention for incarcerated clients?
Well, screening is basically done by the trained correctional staff or mental health staff. If there's an advocate attorney who can basically, that attorney may or may not be the staff member. If the attorney is the counsel to the jail, then of course the attorney may have some input into developing the screening process. Usually departments of corrections have a legal department, and they can assist in developing the suicide screening, or at least providing some input. But fundamentally, the screening instrument is developed by the jail or the DOC itself.
Okay. Our next question is, what is the idea behind jails not prescribing things such as Suboxone, Vivitrol, et cetera, or is this a facility by facility decision?
Well, that's an important question. The the Department of Justice recently has taken a position to educate the jails and prisons across the country, and even demand that usage of buprenorphine and similar acting medications must be the mainstay of treatment using MAT, medication-assisted treatment for opioid addicts. Only 10% of the jails and prisons across the country use that approach. They are working in collaboration with SAMHSA, the federal agency dealing with substance abuse, alcohol and substance abuse, and they are working in collaboration with each other to popularize this particular, approach. Hopefully within the next 5 to 10 years, it becomes much more popular. I do personally believe that because of the extreme recidivism among inmates who are substance addicted, that should be one of the important modalities of treatment to prevent recidivism.
Thank you, Dr. Daniel. I think we got time for at least another question here. Are there any special considerations of risk for juveniles who have been certified as an adult and are isolated for an inordinate amount of time? So if they're isolated for quite a long time.
Well, that is a big issue. There are most often what I found is that juveniles are mixed with the adults. They have no separate unit or wings. It is a significant risk factor because youth itself is a risk factor, and incarcerated youth have a higher percentage of suicide. That is something which we are aware of. Okay.
Okay.
Before we leave.
Oh, go ahead, sir. Go ahead.
Before we leave, I just want to make an announcement that if anybody who is interested in getting the book, in the slides I've included my contact details. You can communicate with me. I will be able to give the attendees 10% discount, and I will ship the book to your designated address, and I will bear the cost of shipping. I just want to make an announcement.
Oh, okay. Thank you, Dr. Daniel. That's very generous. So what's going to happen then is I'm going to, Dr. Daniel's going to send me his slides here after we get done. I'll put them onto the website that I had posted in the chat, which is actually the website you use to get here where you're at to watch today. So whenever you go there, just give us a little time here to get that updated. Once it's updated, you can go there and take Dr. Daniel up on his generous offer. Dr. Daniel, thank you very much for coming in today and talking to everybody. I know we had a couple more questions we didn't get to, but we're out of time right now. But
send the questions to me by email. I'll respond.
Okay. There you go. I'll go ahead and send those to you. And if you want to send back, I can put those on the webpage as well with the answers. So we'll do that as well. So Dr. Daniel, thank you very much. In the chat, everyone is thanking you for taking the time to join us today. And hopefully we'll see you all again next time here at MIMHtraining.com event. And have a good rest of your day. And I hope your power stays on for the rest of the day, Dr. Daniel.
Thank you. Thank you.
Everybody take care. Have a great day.